So I was privileged to give a lecture at the Healthcare Equity Symposium at the AAN. My lecture was entitled Racial Disparities in Stroke, Metrics, Specifics, and Psychosocial Economics. And so essentially what I did was to give an overview of what the problem is. And so we know we've had long-standing racial and ethnic disparities in stroke in the United States. And unfortunately, based on projections, these disparities are expected to worsen over time. What we know is that over the last 2 decades, the incidence and the mortality from stroke has actually gone down by about 25% or so, which is great news. But even though it's gone down in everybody, the disparity, especially the black-white stroke disparity, has really not budged. If anything, in some situations, actually gotten worse. So whatever we do now and in the future to try and narrow or eliminate the disparity, we need to focus specifically on the disparate population. So say, for instance, we know that African Americans, especially between the ages of 35 to 64, are up to 4 times more likely to die from a stroke than their non-Hispanic white counterparts. So we need to focus on that particular population itself, thinking that we're going to have more interventions. That's going to improve care and outcomes generally, but it's not going to narrow or eliminate the disparity. So then I went ahead to talk about what I think should be the playbook for moving into the future in trying to address racial disparities in stroke. So number one, we suspect there are differential effects of hypertension, meaning that it's conceivable that hypertension, even at the same level, may affect Black individuals more than it does affect their non-Hispanic white counterparts. And so I think there's enough evidence to show, one, of course, that hypertension is the major modifiable risk factor for stroke. And there's also evidence, as I mentioned, that African Americans or Blacks may have a more harmful effect from certain levels of blood pressure. So I think that we should have race-based targets in our clinical practice guidelines. While we wait for more definitive clinical trial results and real-world experiences, we should have guidance about certain blood pressure targets for people who are disproportionately affected by stroke, especially Blacks or African Americans. The other issue I raised was the issue of treatment-resistant hypertension. These are people who they require 3, even 4 blood pressure medications to control their blood pressure, and it's still not controlled. And so I suggested that we could use physiological profiling to target certain individuals who might be less likely to be amenable to treatment by our typical anti-hypertensive treatment protocols. We know that African Americans, for instance, have a low-renin phenotype, and this phenotype is associated with a difficulty in controlling blood pressure. So potentially we could have people who have stroke or at risk for stroke check to see they have a low-renin phenotype, and then aggressively treat them to try and reduce their risk for stroke. I spoke about the issue of epigenetics and the need to try and identify candidate drugs that could potentially help to target epigenetic marks in communities that are disproportionately affected by stroke. I spoke about the issue of psychosocial stress, that we need to have studies that validate discrimination skills, have a way of measuring allostatic load to try and predict stroke risk in racial and ethnic minorities. I spoke about the issue of the social determinants of health, in this case, the social determinants of cerebrovascular health, and that we need to incorporate social prescribing into stroke care so we can leverage the input of a variety of multidisciplinary professionals. And then we also need to test the effectiveness of such social prescribing. We need better community partnerships. We need to incorporate the chronic care model into stroke care. And then we also need departments and programs and health systems to develop and sustain ongoing partnerships with their community. Many healthcare systems are centered in communities that are underserved. And so I think these healthcare systems should better partner with stakeholders in that community to better understand the community, to better understand what their clinical needs are, and also to better be able to recruit people in the community into research studies. I think it's extremely important for providers and healthcare system to be culturally competent, aware of the cultural context of the patients that they serve. We need to make sure that organizations, scientific journals, try and make sure that they require people who are conducting studies to report data on race, on ethnicity, and other things when they do studies. And then finally, the issue of workforce diversity. There's no way we can move forward in a substantive way if we do not make sure that we have a more representative neurologic force or medical force caring for patients who are at risk for stroke.